Impressive audience for 8 a.m. SA Node, AV Node talk. I was expecting half the room to be filled, so I'm very impressed. The future is bright. And thank you to Dr. Cooper, Dr. Estes for the invitation. Obviously, a big honor to be up here today. So over the next 25 to 30 minutes, I'm going to do my best to cover the cardiac conduction system from stem to stern as best I can in that allotted amount of time. And as Josh has probably told you a number of times since you've gotten here, we're not going to cover everything over the course of these few days, but we're trying to do our best to lay the foundation, a really solid foundation that you guys will continue to build upon as you get into your EP fellowships and early career. And that's what I'll try to do over the next 25 minutes, is try to build upon what Dr. Asirvatham laid out in the anatomy talk yesterday, and just try to give you a couple extra points here or there to take home and hopefully use in your future practice. So, all right. So this is probably a slide that you recognize, probably shown to you early on in medical school, where it lays out the cardiac conduction system from top to bottom. And this is the way it's supposed to work. So they taught us early on that the wave of depolarization of the heart begins in the high right atrium at the SA node, and it travels through the atria in a timely fashion. Please ignore these intranodal tracts that Dr. Asirvatham told you don't exist. They still exist in a lot of the figures that are put out there, but they travel through the atrium in a top to bottom, right to left fashion, generating that classic P wave that you're used to seeing, right? That's upright in the inferior leads, 2, 3 in AVF, and biphasic in V1, until it reaches the AV node where it takes that natural pause, right? And for about 120 to 200 milliseconds, it waits until it enters the His bundle before branching into the right and left bundle branches. The left bundle branches into the anterior fascicle and the posterior fascicle before everything branches into the Purkinje network, which is designed to deliver that wave of depolarization to the ventricular myocardium, essentially simultaneously, to generate a nice, efficient heartbeat and to generate that nice, narrow QRS that you see on a normal EKG. And then you get the T wave, the repolarization, to essentially start all over again, right? And that happens 100 to 200,000 times a day, and for the most part, it goes very well, right? But sometimes it doesn't go well. It can be interrupted anywhere along this axis, and when there's interruptions is when we get consulted, right? And at this point in your careers, you've probably become pretty adept at approaching bradyarrhythmias on the clinical side, right? Here's an example of a slide that we show our trainees that lays out just a basic approach to bradycardia. Okay, using the 5S mnemonic, okay, stability, symptoms, short-term, source, schedule a pacemaker, right? So stability, first thing you want to do is assess how the patient is doing. Is this a patient that we can slow play and observe, or is this a patient that needs to be in the CCU with a temporary wire? Symptoms obviously are of paramount importance, as you've learned during your consultative EP time. Correlating symptoms to rhythm is arguably the most important thing that you do, because it is what will dictate the difference between observation and something invasive like a pacemaker. And even when there are substantial symptomatic bradyarrhythmias present, you have to make sure that they are not reversible. Are there any reversible causes like medical management that the patient is already on, or some type of ischemic heart disease that is already fixed, that with a little bit of time and observation, the need for pacing will go away? Your job as you become an electrophysiologist is to try to take the information given to you on the clinical side and figure out where in that conduction system is the problem, okay? Because based on where you think that problem is, might dictate whether we schedule that pacemaker or not. Now, symptoms are a squirrely thing, no matter what disease process we're talking about. When it comes to bradyarrhythmias, it's no different. There's a broad range of symptoms, all the way from the asymptomatic to the overt, where people are passing out. And most people hang out here in the middle, where they are lightheaded or fatigued, weak, some degree of decreased exertional capacity, teasing out those things and teasing out their relationship to the underlying bradyarrhythmia is the most important job to decide who gets a pacemaker. Now, over a short talk, we can't go through every single indication and the guidelines for pacemakers, but as you've seen, there's a theme of who gets a pacemaker, right? And in its simplest form, pacemakers go to kind of three groups of people. People who are symptomatic and non-reversible with respect to their bradyarrhythmia. Those are the patients that'll have class 1 indications for pacemakers, whether it be AV block or sinus node dysfunction. Symptomatic, non-reversible, you use those adjectives, pacemaker recommendation is usually what follows. Now, there are some patients that are minimally symptomatic or have no symptoms, but they have a conduction disease present or evidence of conduction disease that makes them higher risk for progression to higher levels of AV block that warrants a prophylactic pacemaker in the absence of symptoms. And then there's always the special case. There's always the zebra. There's always the patients that need pacemakers earlier in the game because the natural history of their disease process leads to an unpredictable progression of AV conduction disease, like patients with myotonic dystrophy or patients with lamin AC cardiomyopathy. Those are the guys sometimes you have to look up to remind yourself what do the guidelines say, okay? All right. Now, the workup of bradyarrhythmias always begins with ECG analysis. And so we'll start with the sinus node. These are things that you've become very used to looking at. These are EKG strips representing some degree of sinus node dysfunction. Up top, you have sinus bradycardia, so someone who's wide awake with a resting heart rate in the 35 to 40 beat per minute range is not normal for the most part. In the middle is an example of a 4+ second sinus pause, okay? And then if that sinus pause is paired with a tachyarrhythmia, like AFib with RVR, like you see on the bottom, we have the so-called tachy-Brady syndrome. Now, any cardiologist can recognize these patterns on EKG or telemetry strips or ambulatory monitoring. As electrophysiologists, you have to take that next step, right? You have to move beyond just the EKG, and you have to dig into the underlying nuances of the anatomy and the intracardiac electrograms that we'll get to as well, in addition during the workshop in a little bit later today. So Dr. Asravatham did an amazing job kind of laying things out yesterday. Just to reiterate some of his points in terms of the anatomy of the SA node. Here on your left is where the SA node sits, largely sitting at the superior aspect of the sulcus terminalis. It's this crescent-shaped structure, as you see here. And importantly, it's a very complex structure, okay? For the most part, it is subepicardial, particularly in the main body, but it extends to the endocardium, particularly below, and it also extends up into the SVC, as you see on the histologic slides to your right. Now, if you dig in deeper, you'll appreciate that extending from that compact SA node are extensions of that special conducting tissue that go into the perinodal area where there are atrial myocytes. And these extensions can be seen epicardial, endocardial, up into the SVC. And they're important because if you map sinus rhythm, you'll quickly learn that there are different sinoatrial exit sites for sinus activation. And they're because of these extensions that come from that main body of the sinus node. And they also are very responsive to the hormonal and neural input into the SA node. As Dr. Asravatha mentioned yesterday, when the heart rate is fast and the sympathetic tone is high, the exit tends to be superior along the SA nodal apparatus. When vagal tone is dominating and heart rate is slow, it tends to exit out lower. And that explains why there is some beat-to-beat variation in P-wave morphology. And based on the heart rate, you can see some changes in P-wave morphology because of those different exits. A quick note on arterial supply of the SA node. It can be redundant. It largely comes from the right coronary artery, 60 to 70% of the time, and from the left, 20 to 30% of the time. The picture on the bottom is illustrating that in addition to that variation, you can also have dual blood supply to the SA node. Here on the bottom right, you'll see a SA nodal artery branch coming off the proximal RCA and another branch coming off the proximal left coronary artery and meeting in the middle. Now, I think this picture does a really good job, as good a job as any figure I've seen, of illustrating the complexity of the human SA node. And it has 4 colors. From left to right, you see atrial muscle that surrounds the SA node apparatus. The SA node is in red, illustrating that this isn't that little yellow dot that you draw for your patients in the room, or you saw in that initial picture I showed you. It's this long structure with extensions into that atrial myocardium, and it can be up to 3 to 4 centimeters long at times. And in addition to that, there's that yellow perinodal area, okay, where the nodal cells are interspersed with atrial myocytes and can impact the physiology of the SA node. In blue is the adipose tissue, right? You saw, it was in your hands, the great amount of fat that is over that SVC-RA junction where the SA node lies, okay? And housed in that adipose are those neural inputs that dictate the degree of sympathetic versus parasympathetic tone, and it dictates the heart rate. And not only is the human SA node incredibly complex at the beginning, it also remodels over time, okay? Just the natural aging process, the comorbidities that our patients bring to the table, like heart failure and atrial arrhythmias, all lead to changes in this SA node apparatus that can lead to sinus node dysfunction or difficulty exiting from that SA nodal area. So here is a figure from Ho and colleagues in 2016 showing a normal control up top, okay, and comparing it to an age-matched patient, 67 years old, that had atrial fibrillation, persistent atrial fibrillation for 10 plus years. And you can appreciate the differences. The patient with AFib for 10 plus years has extensive fibrosis in that perinodal area, as you see starred here. You also appreciate that the presence of nodal cells goes down significantly with long-standing atrial tachyarrhythmias. And then on the far right, you also get a change in the vascular supply to the SA node, okay? The capillaries are less, they're smaller, they're more narrow as time goes on and as the effects of these atrial arrhythmias or heart failure has on the atria. Okay. Now, if that SA nodal area becomes progressively diseased or fibrosed, you may find yourself with an inability to exit the perinodal tissue each time, generating these relatively cool EKG patterns. And typically the cool EKGs are the ones that look really old because there's not great examples of them popping up constantly. But if you get a lot of fibrosis in that perinodal area, you can have difficulty exiting from that, generating sinus exit block. Okay? Sinus exit block happens when the SA node fires, but it doesn't leave, and you can't really distinguish it from a sinus pause, except for the fact that the RR interval will be exactly double the prior RR interval. As you see here, if I can get my arrow, there we go. You have a sinus rate in the normal range, followed by this sinus pause, and if you measure the RR from here to here, maybe I'll use this guy. From here to here, that is exactly double here to here, okay? So again, any cardiologist, any internal medicine resident can recognize a sinus pause, but it takes the EP to come in and make everyone feel dumb to call it sinus exit block. Here's your opportunity. Aspire. All right, so when it comes to the EP study, admittedly, you'll be doing very little bradyarrhythmia work in the EP lab, okay? But it's important to be aware that it exists for both the purposes of having good foundational knowledge of EP and to make sure that you pass EP boards ultimately. When it comes to sinus node recovery time, which is the most commonly used technique for assessing evidence of sinus node dysfunction in the EP lab, you pace from the high right atrium, so close to the sinus node, for 30 to 60 seconds at multiple pacing cycle lengths down to 300, and you measure the longest interval from the end of the overdrive suppression to the first surface P wave. And a normal SNRT is less than 1500. And then you correct that SNRT for the baseline cycle length, and the normal C-SNRT is 350 to 550. I'm going to show an example of this during the workshop, okay? Now, anytime we talk about these structures, I always like to pull in some type of EP correlate from the lab. And the thing that I think about when I think about SA nodal anatomy is sinus node modification, okay? So something that we don't do a lot of anymore, I think is, for good reason, it makes a lot of sense. If you didn't do a day of EP, but you understood the anatomical challenges of the SA node region, it would make sense to you why sinus node modification is not typically very effective, okay? So when I think of a procedure, I always want to think and teach my fellows about what could go wrong. So if you're trying to ablate the SA node, or at least the extensions coming off of the SA node, for the purposes of getting inappropriate sinus tachycardia under control, the things that could go wrong, one, is that you could fail, right? You saw the structure, okay? This is a very long thing protected by fat, mostly epicardial. If you're trying to burn it from the endocardium or the epicardium, it's going to be challenging to have an impact on the main body of the SA node, okay? And even when you have an impact, there's a good chance that it's going to recur in the weeks and months ahead, okay? If you do a good job of ablating the sinus node and modifying it, you might do such a good job that you have to put in a pacemaker. You also saw in that initial slide that the phrenic nerve runs right near that SA node territory, okay? And then last but not least, these patients with inappropriate sinus tachycardia are typically young and otherwise healthy. And if you're hammering their SVC-RA junction, you can cause SVC stenosis, SVC syndrome. And if those patients have a pacemaker, that's particularly a bad combination, okay? All right, so let's move on from the SA node to the AV junction. Now, atrioventricular conduction can go wrong in a number of ways, right? It can be delayed, which is what we see with first-degree AV block. Okay. It can be diverted if you have bundle branch or fascicular block. It can be occasionally interrupted, which is what we see with second degree AV block. It can be frequently but not always high degree AV block, or it can be completely absent, okay, complete heart block. Again, we always want to think about the anatomy, okay? Again, you guys had the heart in your hands last night. And Dr. Osservatham did a beautiful job kind of laying out the pertinent anatomy when it comes to the cardiac conduction system. So Here's the anatomy, right? So we have this AV node right here that Dr. Asirvatham emphasized as something that we can't really see. We can't really measure it, right? We can measure a His. We can put a catheter right on the His, okay? And he put that pin right in the membranous septum where the penetrating bundle of His sits to define which triangle? Triangle of Koch, right? So the triangle of Koch, the apex is there at the His bundle where you have a catheter typically, okay? The anterior portion of that triangle of Koch is the tricuspid annulus. The posterior boundary is that eustachian ridge, tendon of Todoro that comes up, okay? And the base of the triangle of Koch is that coronary sinus os, right? And so even though you can't see the AV node, if you can define the triangle of Koch really well, you can feel comfortable knowing that that compact AV node sits at the apex of that triangle of Koch, okay? Now from that AV node emanates the His bundle, the penetrating His bundle that goes into the central fibrous body, into the membranous septum, travels for about a centimeter, centimeter and a half, before it branches into the right and the left bundle, okay? Here is illustrated the course of the right bundle. The right bundle is a cord-like structure. It doesn't arborize early like the left bundle does. It's relatively superficial, particularly at the basal and the apical aspects of it, which makes it more vulnerable to trauma, okay, or degradation. And then it finally branches towards the end as it enters into the moderator band, anterior papillary muscle region, and divides into the Purkinje network, okay? On the left side, you have the left bundle, which looks a lot different than the right bundle. It's not cord-like. It's more broad. It arborizes early in the game. It gives off multiple fascicles, particularly the anterior fascicle, which runs on the basal anterior wall, okay? And it gives off the posterior fascicle. The posterior fascicle is the thickest of the fascicles. It runs along the infroseptum towards the inframedial papillary muscle, okay? And it tends to be the most robust of the fascicles, okay? When you have block, it's typically right bundle branch block or left anterior fascicular block. It's more rare to see posterior fascicular block, okay? So that's our anatomy, and here's our EKGs. For the most part, a lot of your EP consults when it comes to bradyarrhythmias will be looking at disturbances in AV conduction. So you'll be looking at a lot of EKGs like this, okay? First degree AV block is a misnomer. There's not really block. You have one-to-one conduction, but you have delay from the A to the V, a long PR, greater than 200 milliseconds. Below it, you see the classic secondary AV block, Mobitz 1, what we call Wanky Bach, with its grouped beating, with the PR interval that gets longer and longer until it drops, and then the process starts over again. Below it is Mobitz 2, okay, where you have dropped beats, but that PR interval is not lengthening before the drop beat. And the distinction is important, right? Because they carry different natural histories in terms of progression to higher degrees of AV block. And below it is third degree AV block, where you have Ps and QRSs marching out at their own inherent rates, not paying attention to each other at all. All right. So again, as EPs, we have to dig into the intracardiac representation of these bradyarrhythmias. And here's an example, okay? We have first degree AV block. So we have a long PR interval, as you see on the surface, okay? That PR should be 280, I think. That's interesting. And down below, as Josh laid out for you yesterday, is our His bundle electrogram with our A, our H, and our V. The HV interval is within normal limits. The AH is prolonged. And so the delay in this situation is intranodal, okay? The PR is long because the intranodal conduction is long. When we go to second degree AV block, Mobitz 1, Mobitz 2, here's a classic ladder diagram illustrating what's happening at all levels. So you have the A and the V, the AV node, and the His in between. When you have Mobitz 1, okay, you have that progressively prolonging PR interval, okay? And the delay is in the AV node, 140, 260, 340, 380, okay? So progressively prolonging. And the delta change is going down, so plus 120, plus 80, plus 40, before you have a dropped beat at the level of the AV node, and then it starts all over again. So the hallmark of Mobitz 1 second degree AV block is a lengthening PR with a shortening VV, followed by a dropped beat with subsequent shortening of the PR again. As opposed to Mobitz 2, where you have a very stable conduction time in the AV node until you drop a beat. And you'll appreciate that the block is illustrated here as happening below the node. And that's why in patients with Mobitz 2, that distinction is important, because even in patients who are asymptomatic or minimally symptomatic, we worry that they have a long-term prognosis that has complete heart block in their future. And we tend to offer pacemakers earlier in the game in that situation. Now, sometimes you don't have consecutively conducted beats to determine if that PR interval is lengthening, to determine if it's Mobitz 1 or Mobitz 2. As you see here, we have 2-to-1 AV block. Now, there are still clues to diagnosis, as you may have picked up on already, okay, to a benign versus more malignant process. Now, patients with narrow QRSs, okay, and periodic Wanke box seen on telemetry or ambulatory monitoring tend to have a more benign prognosis. Their conduction also tends to improve with exercise or heightened adrenergic drive, as opposed to the Mobitz 2-like mechanism, where at baseline they might have wide QRSs or comorbid fascicular block. Their conduction can often worsen with exertion or heightened adrenergic drive, and these patients make us more nervous, okay? So let's go to some intracardiacs. All right. So here's a strip from left to right. We appreciate that there is a dropped beat here, okay? Now, if I had to ask you if this was intranodal or infranodal block, what would you say? What would be your guess based on just the surface? What's that? Why? Infranodal was the answer, I agree. Okay, so a wider QRS makes you worry that there's more distal conduction disease. Okay. All right, and here's the intracardiacs illustrating that. So from left to right, we have AHV, AHV, AHV. Then we have an AH, followed by restoration of conduction. And importantly, that AH interval is not changing until you have a dropped beat. And you get through the AV node and you generate a His bundle electrogram, but no V. So these are the patients that make us more nervous, okay? All right, so this is Mobitz 2. Okay, how about this? What's going on here? It's a pretty narrow QRS. So pretty benign. Let them go home. Tell the ER you don't need to come down. What's that? Okay, so I get a vote for complete heart block? Exactly, right? So this is complete heart block. So there's A's and V's marching out, not paying attention to each other whatsoever. You have a relatively narrow complex escape beat that is coming from the junction. So you see a His before every V, but that His V is not paying attention to the A's at all. So this is complete heart block. Unfortunately, you have a nice, relatively stable escape that'll buy you some time, but that patient should not go home. Okay, so just a couple more slides, and then we'll wrap up. So as electrophysiologists, you still have to think about the simple things, right? You have to know what right bundle branch block and left bundle branch block looks like so that you can come in and save the day when there's a wide complex tachycardia and tell them that it's not VT, that it's SVT with right bundle aberrancy or left bundle aberrancy. And this is what right bundle branch block looks like, okay? The QRS is wide. You get a broad notched RSR prime in V1, okay? Typically have a wide deep S wave in V6. And then often you'll have comorbid left anterior fascicular block associated with it, where you have a frontal plane axis between negative 45 and 90. As opposed to left bundle branch block, where the QRS is also wide, but you have a broad notched slurred R wave in the lateral leads, V5 and V6, 1 and AVL. The initial R waves in V1 through V3 are typically very sharp, okay, and small. And then you have STT wave changes that are opposite direction to the QRS. So that's classic left bundle branch block. Now, even left bundle branch block is not as simple as we thought it was, okay? So if we picture left bundle branch block as that little yellow wire in that initial picture being broken, okay, we're not having a full understanding of what it really is. And we know that because if we pace on the His bundle, we can actually correct, in quotes, that left bundle branch block, right? So pacing on the His in a patient with classic baseline left bundle branch block, we can narrow that QRS and engage the native conduction system, despite the fact that we thought the left bundle was broken, okay? And that's due to this concept of longitudinal dissociation, that the fibers that are going into the left bundle are predetermined, okay, at the level of the His, and that the actual disease can be pretty proximal in the AV conduction system, and that if you implant a lead or a catheter, pace from a catheter, below that disease, you can re-engage the native conduction and change that left bundle into a narrow QRS. And from that has grown this new movement. It's not new, but at least the enthusiasm is new over the last 5 years for His bundle pacing, okay? That left bundle may not be permanent. And you'll appreciate on this multimodality imaging slide of His bundle pacing that we are essentially engaging the interventricular septum above the tricuspid valve, the atrioventricular septum, okay? We're trying to plug into that His bundle and capture the tissue below the disease to generate a narrow QRS once again. So in summary, it's really time, okay, to build on your consultative EP knowledge base, to go from just interpreting surface electrograms and taking it to the next step when it comes to bradyarrhythmias by incorporating those intracardiacs. And we're going to take the slides from this talk and dive in a little bit more during the workshop to show you additional examples of intracardiacs when it comes to sinus node disease and AV block. And importantly, it's very easy to ignore bradyarrhythmias when it comes to EP boards. You may not think about it again for another 2 years after today. And the Brady part of EP boards are some of the lowest hanging fruit for you to get your questions right. So here's a representation of the first time success rates for passing EP boards put out by ABIM. And you'll appreciate that the EP exam is one of the hardest exams out there in the subspecialty world, where success rates were in the 80% range for some time. Now, the last couple classes have actually stepped it up and done extremely well. I think 2018 was actually 96%. And we were surpassed by the nephrologists who apparently are not doing as well. But Dr. Estes and Dr. Cooper are actively probably working on questions for the next version to make sure that we have a competitive test. And if you get the Brady ones right, you're going to be well on your way to passing this test. And also importantly, I don't want you to forget that this course holding that heart in your hands, okay, and thinking about the electrophysiology and thinking about the anatomy that you're trying to traverse when you do these procedures is extremely important. If you have a great understanding of the triangle of Koch, okay, you're going to know where the compact AV node is, and you're going to safely ablate AV and RT. Or you're going to successfully do an AV node ablation when you're intending to do that, right? If you have a good understanding of where the His bundle is, you're going to be much better at doing His bundle pacing. If you have a good understanding about the fascicles, you're going to be better at working up fascicular VT or fascicular PVCs, okay? So always keep that in mind. Thank you for your attention.
Some questions, Josh? Further questions? Dan, thanks very much. I think a couple questions. Josh is going to shoot them up to you, and then we'll move on to the next presentation.
One question that came up here is, are we pacing below the level of block in the bundle, or is pacing capturing surrounding tissue and skipping the block? So clarifying the mechanism of recruitment of the blocked bundle.
Yeah, so there's multiple theories, but as I showed you, the prevailing theory is that the fibers for the left bundle are predetermined proximally in the His bundle. And so the disease is actually in the proximal His bundle, and the actual left bundle branch block does not have any disease in it. And so if you're plugging in below the disease in the proximal His, you can recapture the left bundle and generate a narrow QRS, okay?
And along the same lines, defining the anatomy of the His Purkinje system, there's a question that we were told that the His bundle is on the ventricular side of the annulus, and now you said that His bundle pacing is on the atrial side of the annulus, so which is it?
Both, yeah. So the penetrating bundle of the His goes into the central fibrous body. Okay, and that is the atrioventricular portion of the membranous septum. That on the right side, do you remember that slide that Dr. Asarvatham showed you yesterday, where the tricuspid valve was here, and the mitral valve was here, and the interventricular septum was in the middle, and the atrioventricular portion of the membranous septum is an atrial structure on the right side and ventricular structure on the left. So we're plugging in on the atrial side, but we're engaging the His.
And maybe I'll ask one more. The question, if a patient has a third-degree AV block but a good narrow escape complex, and I guess the presumption here is that they're hemodynamically okay, do they need a pacemaker?
Yeah, so typically, unless there's a clear reversible cause, if there's evidence of complete heart block, and even in the absence of hemodynamic significance, that escape rhythm tends not to be a reliable rhythm for the long term in adults. And that even in the absence of symptoms, that's a class 2A indication for a pacemaker.
Yeah, and I would add, I guess, that typically, I mean, obviously people need different heart rates for different activities during the day, and an escape rhythm, while perhaps not resulting in symptoms at rest, might end up resulting in symptoms of chronotropic incompetence, exercise intolerance, if the person needs augmentation of cardiac output. So patients at rest may feel okay, but they just can't do activities because they feel tired, because now their ventricular rate is, 64 instead of 62, but it really should be over 100, for example. So for symptom relief, to have AV synchrony and an appropriate heart rate for activity, people usually do feel better.
Exactly. Agreed.
That said, one exception is congenital heart block. So there are patients who are born with complete heart block, and there's sort of a self-selection. Unfortunately, if there's no escape rhythm, the infant passes away at birth because they don't have a heartbeat unless they're emergently resuscitated. So you're sort of selecting for patients who will have a stable escape rhythm, and sometimes that isn't discovered till later in childhood or even in teenage years, where someone's not keeping up with their classmates on the field or whatever, and they're, oh my God, you're in heart block, and they've been that way for 16 years. So does that person need a pacemaker? It's a complex decision, because committing somebody to a lifetime of intravenous leads, although future technologies may not require that. it is a scenario of debate, but it's not a life-saving thing, but it's a quality of life intervention for many.
Yeah, absolutely. Agreed.
Dan, thanks very much. Be sure to fill out the evaluations.